A very good day to you. I am Jack Tay from Singapore, and welcome to our fourth installment of Tumor Boards in Focal Therapy, organized by the Focal Therapy Society. Focal therapy is a highly personalized intervention with the aim of treating not just only the aggressive cancer while sparing as much of the normal non-malignant tissue as possible in order to minimize side effects and maintain quality of life. And the cornerstone of success, of course, depends on identifying suitable patients for treatment, as well as close surveillance in order to treat any new lesions or recurrences early should they occur. Tumor Boards in Focal Therapy is a quarterly webinar organized by the Focal Therapy Society to help practitioners better select patients and choose salvage therapies through a tumor board style case discussion with commentary by our international panel of experts. And I'm so happy to be joined today by our esteemed panel, comprising Dr. Sunao Shoji, Associate Professor of Urology at Tokai University School of Medicine, Tokyo, Japan. Professor Nathan Lawrentschuk will be joining us later. He's a clinical and research professor at the University of Melbourne and Director of Urology at Royal Melbourne Hospital. Dr. Samuel Yee is a consultant urologist at the Prince of Wales Hospital and also a clinical associate professor at the Chinese University of Hong Kong. And last but not least, Dr. Michael Gorin, well-known urologist, associate professor of urology at the Milton and Carol Petrie Department of Urology at the Icahn School of Medicine at Mount Sinai. So today we have an exciting lineup of 4 cases. We'll try to go through all four of them, each followed by our panel discussion. And for the audience, please input your comments or questions into the chat. And if time permits, I'll definitely direct these to our panel. So without further ado, I'll hand over the control to our first presenter, Dr. Shoji. Sunao, please.
Thank you very much, Jack, for the important opportunity to present my case. My name is Sunao Shoji. I will present a case of selection failure for focal therapy in a patient with an enlarged prostate. Should the number of systematic biopsy cores be increased for the patient with enlarged prostate? Previous reports have highlighted the importance of MRI-targeted and systematic biopsies for the detection of clinically significant prostate cancer. Therefore, MRI-targeted and systematic biopsies are recommended to select patients for focal therapy. The inclusion criteria for focal therapy in your institution are shown. MRI transfusion image-guided target biopsy and 12 cores systematic biopsy were required. Focal regional ablation is performed using high-intensity focused ultrasound based on the 3D location of the significant cancer. This is a case of a 71-year-old male with a PSA value of 15.22 nanogram per ml. His prostate volume was 48 cc and the PSA density was 0.32 nanogram per ml per cc. On MRI, lesions with PIRATS category 4 and 3 are observed in the left peripheral zone and right transition zone respectively. We performed MRI transfusion image-guided target biopsy and 12-core systematic biopsy. The target biopsy revealed the significant cancer with a Gleason score of 4+3 in the left peripheral zone, and systematic biopsy revealed prostate cancer with a Gleason score of 3+3 in the right peripheral zone. Based on the location of the prostate cancer, we performed the focal therapy in left lobe and right peripheral zone apex site. At 1 month after the treatment, no blood flow was detected in the treated areas. After the treatment, patient PSA value was 6.93 nanogram per ml at 6 months after the treatment, but 9.66 nanogram per ml at 18 months after treatment. So we diagnosed the patient biochemical failure. MRI fusion image-guided target biopsy were performed for the treated areas, and 20 course transperineal systematic biopsy was conducted. The additional core of 12 cores and 20 cores systematic biopsy was shown. Prostate cancer was not detected in the treated area. So significant cancer with a Gleason score of 3+4 was detected in the right transition zone on the base side. Based on the patient clinical course, an increased number of systematic biopsy cores should be considered for the patient with an enlarged prostate. In previous report from Jack's team, reducing the number of systematic biopsy when performing an MRI-targeted biopsy lead to reduced detection of significant cancer and alters the treatment plans for focal therapy, possibly limiting the oncological efficacy. The case presented today demonstrates selection failure among patients with an enlarged prostate after focal therapy. Based on this experience and previous study, an increased number of systematic biopsy core should be considered for the patient with enlarged prostate. Thank you very much.
Thank you so much, Sunao. That really was a very interesting case. So it seems like in this case, you feel that the repeat biopsy should show that there was a recurrence after treatment. And I think one of the questions you have is whether the pre-treatment biopsy was adequate. So what is your routine practice on pre-treatment biopsies? Is it how many do you do in the target zone, and how many do you usually do as a systematic biopsy?
Yes, for the first diagnosis of the prostate cancer, we perform the target biopsy at least 2 or 3 cores for the one target. And 12 cores systematic biopsy is a routine systematic biopsy in our protocol. So, however, we added more 4 or 8 cores of systematic biopsy cores for transition zone, depending on the prostate size or PSA density, based on this our experience.
Very nice. And I just wonder what the rest of the panel thinks. Sam and Mike, do you guys do a fixed number of systematic biopsy cores? Do you vary it based on the patient, or do you, is there a fixed template that you use?
Well, thanks, Jack, and thanks, Sunao, for the presentation. And in fact, we do have a fixed protocol, like what Dr. Shodi has said. We have 3 cores of target biopsy for each target that we see on MRI. But for systematic biopsy, we usually employ a modified gene spread protocol. So if it's a prostate, say less than 60 grams, we may go for 9 cores on each side. So altogether, we have 18 cores of systematic biopsy. But if it's a bigger prostate, then we may go for 12 on each side. So altogether, 24 cores of biopsy. So I guess you're correct to point out that, in fact, the prostate size does play a role in the final decision of the biopsy course. Just one question that I probably have missed in the presentation. For the follow-up biopsy after focal therapy, the imaging, the MRI before the biopsy did not show any lesion on the right upper quadrant, which is picked up by the biopsy. Am I correct?
Yes, you are correct. If we could not cancer suspicious lesion on follow-up MRI, we performed a target biopsy for the treated areas and only systematic biopsies.
I see.
What about you, Mike? What do you think? How many biopsies do you do?
Yeah, so my standard practice is to follow the 10 sector technique, where basically you're sampling the periphery of the prostate circumferentially, and then extending 2 cores to a ninth and 10th sector and the posterior lateral aspects of the prostate. This template that's been popularized by Matt Allaway. So in total, that ends up being 20 systematic cores. And then I do anywhere from 3 to 4 cores of each ROI. And if the systematic sort of overlap in spatial area with the region of interest, then what I do is when I get to that area in the systematics, I try to spread it away from the region of interest so I have a higher sampling density in total. I've chosen not to go with the Ginsberg template or the Barzell templates because I think that they tend to oversample the transition zone of the prostate, which is pretty low yield, which is why I like doing the 10 sector technique, where my cores are really concentrated in the peripheral zone of the prostate. Now, with all of that said, it's probably all of these templates are truly inadequate for being able to map out the extent of cancer within the prostate. And that's because, we're only sampling a very, very small percentage of the total prostate area. And you're probably familiar in the literature with a handful of sort of AI-based tools that are out there, which take advantage of tens of thousands of cores that have been taken from prostates over the years. And probably really what we need is the result of, say, our, anywhere from 12 to 20 plus core biopsies, and then augment that information with the knowledge gain from prior biopsies that have been done by other urologists to truly be able to map out these areas of disease. So, doing the best we can with the tools we have available right now, but I think that's where we're going in the future to be able to do this accurately.
Right. That's a really good rundown on what's on the horizon for patient selection, I guess. I think AI is really going to transform things, and taking into account imaging as well as biopsy data. I just wonder, Sunao, do you think that there's any possibility? I think you're holding yourself to a high rigor. You're saying that you might have missed this at the start, but do you think that given that intervening months, that possibly, this was de novo disease, maybe, a bad prostate cancer or multifocal there's a theory about field change. So do you think that there could be field change in this prostate perhaps, and having a de novo cancer occur outfield? What do you think is the possibility of that?
It's a very difficult question. Maybe so PSMA imaging or development of imaging would contribute to detect the more detailed prostate cancer detection. I hope.
Right. Yeah, so hopefully, genomics or some other biomarkers can help us predict, this kind of field change before that occurs. But I think before that happens, I think biopsy is still currently the best tool we have. Sam, do you have any comments?
Yeah, maybe I have one question actually for Sana. Say if you have performed a 20-core biopsy but before diagnosis, and you only picked up the same tumor that you have picked up like this case, and with the negative MRI on follow-up, do you think you still need a 20-core on your follow-up biopsy, or you're pretty safe to go ahead with less cores? Because sometimes the deterrent for patients to come back for repeated biopsy is it is not a very comfortable procedure. So the more calls we take, especially in Hong Kong, most of our cases may need to be done under local anesthetic instead of a general anesthetic or MAC. So the shorter the procedure, sometimes it'll be easier for the patient. So I wonder if you have done a quite comprehensive survey in the first time before diagnosis, would you still go ahead for such an extensive biopsy on follow-up?
Yes, at this present, our protocol is 12 core systematic biopsies, but we have a possibility to modify the number of the biopsy cores depending on the PSA density or some biomarkers or more detailed imaging development, I think.
Mm.
I
Yes, I
think
guess. Yes, Mike, please go ahead.
I was going to say, I think more so than the number of cores in follow-up, probably of more so or probably of equal importance is, what is your template that you use when you resample someone after an ablation? When we do a systematic biopsy at the time of initial diagnosis, our objective is quite different than when we're doing this in follow-up. Do you sample the entire prostate? Do you just sample in field of where the ablation was? Are you looking for a technical failure? Or are you looking to resample outside of the area of the lesion, looking to see whether or not there was a selection error made? My approach has been to sample for both technical and selection failures early on, but I do think it's very reasonable to do, just a sampling of the lesion or the area of ablation itself, looking for a technical failure, because you've already convinced yourself just several months earlier that it was appropriate to proceed with ablation. So then how many cores do you take of your ablated area? Do you sample the periphery of the ablated area? All open questions, I think, in our field.
Yeah, those are great comments and really a great segue to the next case. So maybe we should have Sam put up his case, which is on the question of biopsy after focal therapy, and we should look at that case and then continue this discussion.
Sure, thank you, Jack. Maybe we can show this slide for the moment. Great. Okay. So this case, in fact, we are trying to look at the issue of follow-up biopsy after treatment. And good morning again, and good evening to all. I'm Samuel Yi from the Chinese University of Hong Kong. And here's a patient, age 66-year-old with good past health, presented with PSA 5.8, not exactly very high, with not very good erectile function. But we still concerned about the continence function. And after discussion, the patient proceeded with MRI. And on the MRI, we found two lesions. One is on the left side, one is on the right side, both pyreth 3 as can be seen on the images here. And upon fusion biopsy, we found that there were Gleason 3+4 lesion on the left parietal zone, together with Gleason 3+3 lesion in the left anterior zone. For this patient, in fact, the prostate is not particularly high, but big. I mean, just 31 mil. And the distance between the rectum and the most anterior part of the prostate is 33 millimeters. So in fact, even if we are trying to do almost a hemiablation, both HIFU and cryotherapy would be an option. So maybe it's time for a bit of discussion and see, because I know from the panel, we both have the experience of cryotherapy and HIFU. So for this lesion, I wonder what modality would you guys pick? Would you go for transperineal ablation like cryo or transrectal ablation like HIFU? Maybe Dr. Shoji, I know you have very vast experience with HIFU. In this case, do you think it's a good candidate for HIFU ablation?
Yes, I think so.
Yeah.
Good candidate, and, but I have a little bit concern. This patient has a conductor length is a little bit long, so as a focal therapy inclusion criteria, so sometimes we are wondering for such a case.
Yes, yeah. But so sorry, Jack, please go ahead.
No, I think Mike had some comments. Mike, please go first.
Yeah, I mean, I think for posteriorly located tumors, I think as a general rule, HIFU is a preferred modality over cryo, in particular because of concerns of being able to, deposit cold enough ice near to the rectum. So I think, generally speaking, most follow the practice of HIFU for posterior lesions and cryo for anterior lesions if they can't be reached. However, from a energy selection standpoint, overall, I have favored over the years cryotherapy to HIFU because I think you get a more confluent treatment area and you decrease the likelihood of skip lesions and so, minimize technical failures. In recent months, I have basically moved entirely towards cryotherapy, even for posterior lesions, because now in the United States we have routine access to perirectal spacers. So we now have Spacer and Barrigel on the market. Barrigel being optically clear. Clear on ultrasound. So now, really, for the first time, I could administer a spacer, get that prostate away from the rectum, and still be able to preserve visibility on ultrasound. So, because of my concerns about skip lesions, now even for a tumor like this, I would do it with cryo.
Yeah, that's really a very interesting point, Mike. And I think the field is very excited to have Barrigel. I mean, I think we all saw the potential in Spacer, but with Barrigel, really you can see through with ultrasound and really deposit that spacer and still have a good visualization on your lesion and where you're placing the needles. Yeah, so I think like one question that has come up recently is we used to talk about the a la carte model, right? That was published by Montsouris, where we do cryo for anterior and HIFU for posterior. And now with these spacers, is a la carte out of the window, and we can essentially cryo anywhere. I think at the end of the day, it still depends on the expertise. I mean, I wouldn't recommend a posterior cryo to a beginner, I guess. But for those of us who are familiar with cryo and know how the energy works, I think that's still possible. On a personal note, I just noticed this Gleason 3+4 core that's next to the urethra, Sam. So personally, I always feel a bit nervous about that because I do use a urethral warmer, and I find that means that I don't get that cold. Ice doesn't get that deposited that well in about 5 millimeters around the urethra. So I just wonder what you think about that, and perhaps what Sunao and Mike think about that with respect to HIFU and cryo respectively.
Well, you're very correct. I think when it comes to the lesion near the urethra, for HIFU, I usually would do it without the Foley incisor, without the catheter incisor, and it still gives me quite good comfort that the energy ablation can cover the lesion. But with the urethral warmer, with cryotherapy, sometimes if the lesion is very near to the urethra, I may not be so certain that I can put enough ablation around that area. So I occasionally have some thought that either I slow down the rate of the urethral warmer, the flow of the warming fluid, or sometimes if it is actually within the central part of the prostate, where in fact, imagine if we are putting ablation around the area, the impact on the urethra or so-called urethral stricture is not much of a concern. I guess that it can be an option to some extent. So you're correct to point out that for lesion near the urethra, sometimes the urethral warmer can be a headache.
Yeah, I mean, I think for unilateral ablation, I really don't have that much concern about, like Dr. Yi had said, either stopping the warming catheter altogether or just pausing it, briefly while I hold the ice in that one probe. I think concerns about needing a warming catheter really came about in the early days of cryo when we were doing whole gland treatments. But I think for hemigland or even sub-hemigland, quadrant ablation, I'm much less concerned about the ramifications of turning that catheter off.
Right, but you still do use a catheter. It's just that you feel more relaxed about turning it off at times.
Yeah, absolutely. So I'll keep it in place. I always have it in there. And for instance, if I'm ablating, say, the lower left or upper left quadrant in a case like this, I'll keep it running And I'll even, run the ice in the area near the urethra, but then I'll go ahead and, turn it off or slow it down. And you could visibly see that ice start to grow the moment you turn that thing off or slow it down. I think more so than it warming, it's really the convection that's sort of, keeping the cooling from happening. So just turning it off, that abrupt change in the convection is enough to allow you to get ice to start to form closer to the urethra.
Very nice. Great tips for aspiring cryotherapy or current cryotherapy users. So now I think you made a very interesting point just now that I just wanted to visit, which was that you talked about the length of capsular contact. And yes. I think, there's been some suggestion that, that predicts like T3. So, do you have some criteria that you follow in terms of the length of capsular contact in which you would be uncomfortable to perform focal therapy?
Yeah, so in a protocol, so less than 10 millimeters capsular length is important for the patient selection for focal therapy. So, I asked the simple question for Same. Yeah. But maybe this case is good cause, so it's no problem. I think it's good case. Yeah.
Well, thank you for pointing out this aspect of case selection. So far in my center, the length of capsular contact is not one of the criteria that we look at. Somehow we still quite rely on the MRI images. So even if it may be a bit long on the capsule, but if there's no general suspicion of extracapsular extension, we still proceed. I guess it really depends on our trust on radiologists as well, because we do discuss the cases together. But I think you have made a very good point, because in fact, if it is not obvious in MRI, but if the patient does have some extracapsular extension, in the end, it would not be a very good case for focal therapy. And I think you have raised a very good point that for this case, rather than the distribution of a cause, which may which may call for a hemiablation, it's not the reason not to go for focal therapy. In fact, sometimes it's the characteristic of the target lesion itself, rather than the number of cores on one side.
Yeah, really interesting discussion. And I think those who are more adventurous with cryotherapy I've heard them tell me that, you can drive the ice out of the prostate. So, that could cover potential, small areas of extracapsular extension. Mike, what do you think? You have extensive experience with cryo. So would you treat someone with a broad length capsular contact, even suspicious for extracapsular extension, or would that be a no-go for you?
Yeah, I mean, I got to be honest, it's hard enough to find focal therapy candidates as it is. If I started using capsular contact alone as an exclusion criteria, I'd be down to performing no cryo, or no ablations, I think. Yeah, I mean, I definitely agree with Dr. Soji that the literature is absolutely clear that the longer linear length of capsular contact, the higher the likelihood of EPE. But, what we're really talking about here is microscopic EPE. And, I wouldn't dare to suggest that I have such exquisite control with with any of my ablation modalities where my concern is such that I can't get, just, beyond the capsule within a millimeter or two. So I see no problem doing that. Now, obviously, gross EPE is a no-go for subtotal therapy. But no, the degree of capsular, a contact or even just a little bulge in the capsule is not enough for me to break a case.
Cool. Yeah, Sam, we should probably
proceed. Right.
Yeah.
Okay. So in the end, I did almost like a hemi-gland cryotherapy for this patient. So it's just a bit of the details of the cryoablation. Started off at 30% energy and then ended with 50 to 60% maximal power. And in our center, because we still have within our protocol a very early MRI, a 1 week MRI to assess the ablation zone. So we have the benefit of having some early MRI images after the treatment. And as you can see from the images here, it's almost like a hemigland ablation on the left side of the prostate at 1 week. And the images are quite reassuring that we are covering the lesion well. So maybe
this is a great example here. You could see the levator muscle's been partially ablated, so you went well outside the capsule there. No concern.
Yeah. Well, probably in the beginning, it's not an intentionally to that extent, but in fact, I think it is a good discussion point because from my previous description, in fact, my maximal power even was not drawn up to 80%. The maximum power is 60%. And then it resulted in such so-called well-covered ablation. For the technical discussion, because I know on the panel there are very experienced cryotherapy focal surgeon here. Do you think it's necessary to drive the power all the way to 80% or 100% in order to achieve the effect? Or just like in this case, it seems that sometimes even to 50 or 60%, we can achieve the kind of ablation we have wanted in the first place.
Yeah, so what the power for me is it dictates the amount of time required to achieve the isotherm you desire, and less so about the temperature that's actually achieved. You could have achieved the exact same ablation at 100% power, but probably in 30% or 50% less time. But I think your ablation is going to be the exact same no matter what you had done.
That's true. Jack?
Yeah. I think I kind of agree with Mike. Often, if you drive one needle at 100%, you will find that it reaches some kind of maximum size. It doesn't really go beyond that. It's just how fast it gets to the size. But I do find that when you combine, 2 or 3 needles that are fairly close together, it can result in a larger ice ball. Having said that, I tend to do between 80 to 100%, and I'm very visual, so I really go by how I see the ice expand out. And control the size of the ice ball. But I do know that for anterior, you sometimes can't see it that well. So if I have concerns about that, I would put a temperature probe there. Just to highlight, I read an interesting paper by Hash Ahmed and group, and he used various needle configurations, I think in a tub of water or gel. And then I think he reported that at duty cycles of less than 70% or 60%, they tended to be gaps in the ice that was formed. You don't form a complete ice ball. So I wonder whether that could sometimes cause infield treatment, recurrences, similar to how we stack HIFU treatments and stack multiple focal treatments together. So I normally don't go so low on the duty cycle. But having said that, it looks like you got a great result here.
When I show my case,
Mike.
Yeah,
Mike. When I show my case next, I'll highlight one of the technologies that I'm using that allows me to intraoperatively plan out relative to the needle position where the ice is going to go and what temperatures are going to be achieved where based on the known isotherms. And it's been my experience that if I ramp up at a low power, or I just immediately hit the gas at full speed ahead on it, the ice ends up in the same spot every time. And so my practice has now become just if I'm comfortable with where my needles are and where my isotherms are showing on the intraoperative display, just go for it. 90% power. Sometimes I'll be a little bit more cautious and work anterior to posterior, but I'll start with those anterior needles at a very high power, and then just when I'm ready for the posterior ones, turn them on similarly. And like I said, I'll show that technology in the next case presentation. I'm curious what folks think about how this conversation carries over to that technology.
Sounds good. This is a great segue. So let's shall we run through the rest of this case, and I think we've had lots of interesting discussion on this part.
Yeah, sure, definitely. So it's just a side story. My patient, after focal therapy, there was some back pain, and he went to not a very knowledgeable general practitioner and somehow suggested him to have a PET scan. and then it picked up a lesion on the right side of the prostate. I don't think it is of much relevance in terms of the FDG PET scan, but just want to see whether you would employ the use of PSMA scan as a follow-up after focal therapy, because I think right now the sensitivity and specificity of PSMA scan is quite good. And in the field where we are not quite sure how to pick up recurrence, whether you would consider using PSMA in your follow-up.
Just to be clear, is this a PSMA PET or an FDG PET?
No, this is FDG. So this is not something that we do routinely. It's just a patient going to a general practitioner having something older. But I guess it can be like triggering a decision or a discussion whether you would think that there's any role of PSMA when we are coming up to the follow-up investigation after focal therapy.
Right, and I just want to just a quick pause to welcome Nathan, who has joined us online as well. And this is this question came just in time because Mike has done a lot of work on PSMA, and Nathan has quite a bit of experience as well. So, Mike, why don't you take that question? Do you think that PSMA is going to be?
I think based on the results of the primary trial from Australia, I think PET has a lot of potential to be helpful in helping you pick out occult sites on MRI of clinically significant disease. In the setting of men who are not yet diagnosed, it adds about 10% in terms of sensitivity.
Yeah, I would echo that. Thanks for having me along today at this tumor board. Obviously, we have a significant amount of experience with PSMA PET for many, many years. And indeed, the advantage we have in Australia is, as of late last year, PSMA is funded for anyone with intermediate risk disease, so PSA over 10 or Gleason 7 and above. So, in fact, when we have patients, and a lot of our patients who want to have focal therapy, they are indeed right in that zone. So they're getting a free government-funded PSMA PET before treatment. So we routinely, even prior to this funding, we would always do a PSMA PET at 12 months in our focal therapy cases, for which we use irreversible electroporation or nanoknife. So we think it is absolutely integral for patient selection, but also for follow-up. And we talk about all of the ducks lining up, and the perfect focal therapy case for me is intermediate risk disease in one zone that is also lined up on the PIRAD score of 4 or 5 on MRI, and with beautiful uptake on the PSMA PET that lines up with the biopsies. That, to me, is the absolute ideal fundamental case for focal therapy. And I think PSMA PET increasingly will have a role, not just in selection, but follow-up.
Nate, I think you had us at the two words, free and PSMA PET together. I think we all want to emigrate to Australia now. I know that you've done PSMA PET before nanoknife in much of your series. So did PSMA PET pick up a lot of lesions that were not detected on MRI? What's your ballpark on that?
Yeah, look, as we know, approximately 30% of patients will indeed have unifocal disease. You can talk about index lesion disease and whether we're missing some very small foci of Gleason 6. But probably I would, from the patients who turn up wanting to have focal therapy, I'm a little bit concerned when there's higher uptake areas, particularly SUV maxes sort of well over 5, outside of areas that were found on MRI. And certainly I was going to raise a question with the group. We pretty much still in Australia do a confirmatory biopsy between 6 and 12 months for patients who we want to remain on active surveillance. And I guess my question, which dovetails from this, is, do we need to do a confirmatory biopsy on somebody before we say they're fit for focal therapy? We certainly seem to do it for active surveillance, and I wonder whether we should be considering that. And obviously, as part of that, if there were any additional targets found on PSMA PET, then those would be targeted. And I wondered what the attitude of the group is to that as a specific question, because as we all know, focal therapy is about selection, selection, selection.
Yeah, that's a great question. And I think this segues in the next part of the presentation. So Sam here has a great case, treated, PSA came down, and he's got a good result. So Sam, do you want to show us this part of your case?
Yeah, maybe I just go through the case quickly. Now, the patient finished the focal therapy, and you can see that the PSA has good reduction at 9 months is 1.95. And I think some of you may have experienced that after focal therapy, instead of the prostate or the treatment area being very atrophic, sometimes the involution will give rise to some cystic collection kind of appearance on MRI. So I think normally at 9-month MRI, when I have this drop in PSA, the atrophic ablation, so I may still go ahead for follow-up biopsy to confirm if there's any infield and outfield recurrence. But this case, because there's some cystic collection around the ablation area, I had some hesitancy putting my biopsy needles in because I don't want to introduce any risk of infection, making it forming some abscess in the later part. So I would like to raise the question now. Say if this is a normal atrophic ablation area with such a good drop of PSA, would the panel still proceed with routine biopsy? And the second question is, now you're seeing there's some cystic collection in the MRI. Would you change your position, just forgetting one follow-up biopsy and keep observing with PSA and MRI? You guys can express your view for the moment.
Yeah. So now, what do you think? Do you get these cystic appearances post HIFU, and would you biopsy everybody, or are there people you wouldn't biopsy after focal?
In our experience, a negative predictive value of combination of PIRATS category with and larger than 3 and PSA density with and larger 0.068 were 97.4% for the detection of clinically significant prostate cancer in routine follow-up biopsy at 6 months after the treatment. So based on our result, we stopped the routine follow-up biopsy. So follow-up biopsy is performed for the patient with only biochemical failure after the treatment.
Okay. So how about Mike and Nathan? Do you still do follow-up biopsy routinely after focal therapy?
Yes, we've got a registry, so we're trying to learn and understand from our cases. And I think from our perspective, we think that biopsy still trumps any imaging, whether it's MRI or PSMA PET or even PSA. And to get those out of field recurrences as well, biopsy is going to be the gold standard.
Right.
Yeah, I'm constantly trying to learn from my cases and make technical modifications on that basis. So because of that, I routinely do a post-ablation biopsy somewhere in the range of 9 to 12 months after the ablation. My focus at that point in time is really on technical failure. So, I tend to be heavier on the sampling in-field as opposed to out-of-field. I do have concerns about the use of MRI at this point in time. The PIRAD system was really intended for treatment-naive glands, and I find that they're rather hard to interpret at this time point. So I've dropped from my practice getting them all together. And because I use the Koelis Trinity system for performing biopsies, I basically do what's known as a second look, where I take their most recent ultrasound and I fuse it back to their reference composite ultrasound MRI fused images from prior to treatment. And then I go ahead and have my original target then superimposed on my post-treatment ultrasound, and I go ahead and sample what should have been the treated area.
Yeah, same for me.
Mike.
Yeah, I do that as well. So I don't use Koelis, but I do go back and I have my radiologist mark up the treated area to look for infield, and I do a systematic biopsy as well as target any new target. So I don't feel comfortable to move away from biopsy yet, although lots of people are talking about it. I mean, PIFABS has just been proposed to do a follow-up MRI scoring. This is great discussion, and I just want to move our session along. So I think I want to move into Mike's case next. And Mike, would you like to tell us a bit about your case?
Sure thing. So thank you again, Dr. Tay, for the invitation to be a part of this esteemed panel and talking about focal therapy for prostate cancer. For those who haven't had a chance to meet yet, my name is Michael Gorin. I'm a faculty member at the Icahn School of Medicine here at Mount Sinai in New York. Should be able to drive the slides, right? It's not responding to my keyboard. Oh, there we go. Should be working now, I think. Okay, very good. So here's my case presentation. So this is a 68-year-old gentleman with reasonable medical comorbidities, hypertension, diabetes, but well controlled, with a history of BPH, who presented in 2019 with an initially elevated PSA level to 5.79. Over the years, his PSA has been high at 16.2, and it's been fluctuating now for several years. When I first met him, he had a high IPSS score, or I say moderately elevated IPSS score of 11 with a quality of life score of 3, despite being on daily Flomax, with moderate bordering on severe erectile dysfunction on PRN sildenafil. Normal rectal exam, but given his PSA elevation, I went ahead and ordered a multiparametric MRI of the prostate, which showed 2 PIRADS4 lesions. This is what his PSA trajectory looked like when I first met him. You can see he's kind of been all over the place, as we frequently see in men with BPH. So this is his pre-biopsy / pre-treatment multiparametric MRI from 2020. And you can see he's got 2 PIRADS4 lesions in this very large prostate with a large number of BPH nodules. This is kind of a cool case. We were talking about modality, selection modality, right? Because this gentleman has a lesion which you would think is terrible for cryo, right? But he's got another one which looks like it would be very good for cryo, especially considering the height of his prostate all the way up there anteriorly. So I performed a transperineal prostate biopsy in early 2020 using the 10-sector technique that I had mentioned earlier. And he had grade group 2 disease in lesion 1, again, lesion 1 being the posteriorly located lesion and lesion 2 being the anterior lesion. In that anterior lesion, he had grade group 3 disease, but in the systematic, he had grade group 1 in the PZPL and PZA systematic cores. So basically, cancer in the systematic cores in the intervening area between the 2 PIRADS4 lesions. So, I discussed with him his usual treatment options for unfavorable intermediate risk prostate cancer, which included radical prostatectomy, radiation with short course hormones, and subtotal prostate ablation. And in particular, this patient opted for subtotal ablation because he was concerned, being he was, so limited in his erectile function already, still able to have, sexual relations, but really teetering on the edge of complete collapse. So he was attracted to focal therapy or subtotal prostate ablation because of that. And in addition, he was interested in the data I had shared with him that cryotherapy in particular does offer improvement in LUTS in patients who undergo this treatment. And he was struggling a bit while on tamsulosin. So in late 2020, he underwent a targeted cryoablation of his 2 lesions with a 0.5 centimeter margin using the EndoCare CS system with V probes using BK fusion. So I had talked about sort of the technique that I use for doing this. Just sort of to show a bit about that technique, and then I'll go back to the case presentation. Unfortunately, I did not have the images available to me for this patient. So the images I'm showing you here are from another case. As probably some of you know, I changed institutions about a year ago, so I don't have those case data anymore. But anyway, what you're looking at here is the intraoperative view using the BK fusion system. And what it allows us to do is we're actually able to plot out relative to the V-probe settings from the tip of the needle where we would expect to get our -20 and -40 isotherms. We could also segment out the prostate, neurovascular bundles, rectum, and so forth, lesion as well. And so, upon placement of your cryo needles, you actually have a sense, even before the ice starts to form, where it's going to form, whether or not you're engulfing the lesion, and so forth. And so going back to that power discussion, I find that it really doesn't matter what power you set this to, because your ice isn't going to form any further than these the contoured out ice balls. So, as has been mentioned by one of the earlier speakers, it still is my practice to get an early MRI, usually within a month of ablation. Not really looking for a multiparametric MRI so much as I'm looking for a perfusion phase, looking to make sure that at least there's a suggestion of technical success. And here you could see how that ablation zone is conforming almost perfectly to what was predicted intraoperatively using this technology. Then it is my practice, as I had said earlier, to do some cross-time point fusion for my intraoperative images and post-op images, preoperative images, and so forth, to make sure I've got a good ablation. And here you can see the contour from the preoperative scan fused back to that 1 month time point, and you can see the entire lesion was engulfed by ice and now has a perfusion defect to it. So just from a technical standpoint, those are some things about just how I perform my cases, although I don't have images to show for this particular case. But anyway, so as I said, he underwent the ablation in late 2020. I did my pelvic MRI with contrast 1 month postoperatively, and it showed a lack of perfusion to the areas of ablation. So basically that anterior lesion and that posterior lesion both had nice defects to it. His PSA initially declined to a low of 3.5. As was one of the reasons for him for selecting this modality. His IPSS declined significantly to a value of 2 with a quality of life score of 0 off of tamsulosin, so he was quite pleased from that standpoint. And his shim declined to 6 at 6 months postoperatively, which isn't really much of a decline from his starting value of 8. As I had mentioned earlier, it is my practice to perform a protocol-mandated biopsy at about a year following ablation, and it showed persistence of grade group 1 disease in lesion number 2, which is that anterior lesion. Despite this, however, the patient opted for PSA surveillance in lieu of retreatment. So this is, his continued trend in the PSA. This is where the cryoablation was performed, and you could see he had a, probably about a 40% decline in his PSA from pre to post ablation, and it continued to decrease nicely for a year. However, in recent months, the patient made a trip to come see me in New York from previously when I was in Maryland, lo and behold, with a PSA result of now 6.97. So a repeat MRI was performed, not by me, but by another provider in Maryland, and I'm glad they did so at this particular time point, because it showed a lesion in the area of what should have been his treated lesion number 2. I repeated his PSA in 2023, about a month later, and it showed some decline to 5.11. Of course, we were rooting for stability or decline. And so now the question is, what do we do in this patient? How do we work him up further? So you could see here that PSA spike he had, and then followed by, a slight decline, but overall now his PSA is higher than it was pre-treatment. Of course, keeping in mind, this is a guy with a large prostate. I think it's about 75 grams. He's got, significant BPH nodules all throughout the prostate. Now he's got this MRI finding. Is that MRI finding, disease or not? Is this just a benign rise? So, here's what the MRI looked like. You could see here that he's got that T2 sort of charcoal smudge sign here, and then some restriction on diffusion-weighted imaging, which in a treatment-naive patient, I think we all would agree is most likely disease. In this state, given the fact that he had grade group 1 disease on his needle, most certainly is disease. So, what are the next steps? What are the options that we have? And so I outline what the potential next steps are. And then I think probably, Jack, maybe you want to riff off that and moderate a discussion around those options at those points. And then I'll tell you guys what I did. So, one option is continued observation with PSA surveillance, given that's what the patient opted for, knowing that he had grade group 1 disease in that area. We could go ahead and proceed with a repeat biopsy at this stage. We could just simply retreat it without a biopsy, recognizing that his first initial post-ablation biopsy was positive, albeit for low-grade disease. We could image with PSMA PET CT, or we could do a combination of options of above. So I'm curious what the group has to say.
These are great points, and you've organized this so nicely for us. Let's go around and see what the others think. So, Nate, what would you do? You're muted, sir.
I would do a PSMA PET and a repeat biopsy. So targeting the MRI area and anything else thrown up on the PSMA PET.
Great. So now what would you do?
So I will perform repeat biopsy, which including the MRI target biopsy and template-guided systematic biopsies.
Okay. Sam?
Yeah, the same with Dr. Shoji, target biopsy with systematic biopsy.
Yeah, so for me, I think that, that lesion looks pretty obvious. It's getting larger. And I also note that it looks like there seems to be a lack of treatment effect in that area. So it could have been a geographic miss or something like that. So repeating a treatment, I guess it's reasonable, but I would do a repeat biopsy. I think just to summarize the themes from everyone, sounds like we are all looking not just at the target, but we also want to know whether there's occult multifocal disease. That's why Nate wants to do a PSMA and the rest want to do a systematic biopsy as well. So I think that seems to be the general gist of how we feel.
Yeah, so I agree completely with Nate, and I opted for first imaging with PSMA PET CT. And then once that result is back, proceed with a repeat biopsy. This is a guy who I just saw in recent weeks, as you can tell by the dates. So those results are still pending. He's to get the PSMA PET scan in the near future. I should point out, though, that I'm interested in the PSMA PET for a slightly different reason than Nate is in this case. While it certainly is possible that the patient has disease outside the ablated areas, I still question, and I've made this point earlier, I still question the utility of multiparametric MRI in a patient who's had an ablation before in the past. In contrast to that, PSMA PET, if there's no active prostate cancer, there, the radiotracer shouldn't be able to bind. So, seeing that lesion, I really want to see, am I going to see radiotracer uptake in that lesion? Of course, I'm going to be interested and want to sample the stuff outside the area that's positive on PSMA PET. But for me, it's really about gaining further clarity on whether or not, that area on the post-ablation MRI really represents disease. And look, we're going to learn something from that experience, right? Because otherwise, we are just left to assume that MRI is accurate in this setting, and we really don't know so.
Very cool. I think interesting points.
So is it all right if I move on to the next slide?
Yep, I think so.
So just to further facilitate the discussion, obviously this is a treatment failure, depending on how you define treatment failure, but, I consider any case that doesn't go perfectly a failure. So the question is, what could I have done differently here? I'm curious to hear the group's thoughts. In looking at this case, I definitely think probably stronger consideration should have been given to just performing a hemiablation. I mean, what was I sparing him by doing two focal areas like that? Well, in truth, what I was sparing is really the cost associated with the cryoprobes, right? Because here I did a case probably with 3 probes, maybe 4 probes at most. To do a hemigland ablation of an 80-gram prostate, you're probably looking at 6 probes. And at about $1,200 a probe, it adds significant cost. So that's probably the only reasonable rationale for why I did it that way. But I think hemiablation would have been quite reasonable. Larger ablation margin, I think, is in that same vein. Reimage sooner. This to me is a real question mark here, because as you've heard me, say a few times now, I do question the utility of multiparametric MRI in this setting, but certainly I could have moved to a PSMA PET. Or should I have just retreated immediately at the time of the first ablation biopsy, that showed that there was persistence of grade group 1 disease? Of course, there's also, a combination of these. So I'm curious what the group thinks, I could have done differently, and what we can learn from this case and what others could do differently in the future.
So as the moderator and seeing that we are running low on time, I'm going to ask the group to hold that thought, and perhaps let's revisit it after hearing Nathan's case, because Nathan has a very similar case. You can see what he did to salvage a patient after a focal therapy failure. He has a very interesting video clip as well. And it also segues back to our Barrigel discussion, which we used earlier, how that's changing how we do focal therapy. So, Mike, let's hold that thought, and we're going to definitely come back to that question. We're going to overrun a little bit today because we're having a really great cases and a really great discussion. So I think we're going to overrun by 5 to 10 minutes. That's going to be fine. So just to let our audience know. Nate, please take it away.
No worries. I'll try and move quickly through this. And as you know, at these sort of talks, everyone likes to show their best case. Well, we can also show some of our more challenging cases. This is a patient, a 62-year-old, who was treated back in 2019. He had Gleason 3+4, pattern 4, 10% in about 4 cores, all from the left base of the prostate. His PSA was 6.3. He had also previously had pelvic radiation for rectal cancer and a resection. We thought that he would be a good candidate for NanoKnife. You can see here that the MRI showed a PIRADS 4 lesion. The PSMA PET, interestingly, showed some uptake in response to that, but it wasn't lighting up fantastically well. But, nonetheless, there was sort of some alignment there. So we went on to treat him with the NanoKnife with 5 needles. That all seemed to go well. At 6 months, he had we do all patients get a 6-month PSA and MRI and a 12-month PSMA and biopsy. Now, unfortunately, a nasty little thing called COVID intervened, and this fellow didn't quite have the PSA that we wanted. So actually, in fact, his PSA fell from 6 to 3 initially, and his MRI suggested treatment artifact. This was done a little bit further on, suggested treatment artifact at the left base and a possible right apex lesion. But in fact, I spoke to this fellow. He was from interstate. His PSA started to rise again from the base of 3 back up to 9.6, which was well above his initial area. You can see there the PSMA PET scan now looks significantly different. There's an area there at the bottom left, obviously coexistent with his previous MRI, but also an area at the right anterior gland. He was biopsied by a colleague, 3+4. This time pattern 4 had risen to 45% from 10%, with 3 cores on the left, and there was a small amount of Gleason 6 in that right anterior area. Now, my call to the group here is what would we do? Do we retreat him? Do we offer him radiation? But we can't because he had radiation before, but I thought I'd just put there because that's usually an option. Or radical prostatectomy. I'm not sure if we have a quick straw poll what we would do there.
Sam, we want to start?
Yeah, sure. I think it's definitely a tricky case. If he doesn't have history of rectal surgery, I think radical prostatectomy may be a bit high on my list. But with his history of rectal surgery, probably I'm more inclined to repeat focal therapy for this case before I would go for regular treatment.
So now, what do you think?
So I will select radical prostatectomy or radiation therapy. So I have 2 cases experience of salvage robotic radical prostatectomy after focal therapy with HIFU in myself. In the cases, slight adhesion was noted around the treated area, but that's a very slight. It's not so difficult to treat. So radical prostatectomy is good treatment option, I think.
Okay. Well, you'll see here, I've just put up a couple of key papers from Paul Cathcart, who actually trained with us in Australia back in London. They've looked at robotic surgery after
Can I ask a quick question?
Oh, yeah, sure.
So I know that you're about to go through some of the literature on radical prostatectomy after focal therapy. This case was done with IRE, right?
Yeah.
So, I was going to say in my hands, I would not include radical prostatectomy as a salvage option for this patient because I just have no experience performing radical prostatectomy after IRE. And admittedly, not knowing the literature as well as you're going to present it here, it seems like there's a void in the literature on salvage prostatectomy after IRE. we definitely know the experience after HIFU and cryo. So that's my only sort of concern there with this case.
Yeah, look, I look to the UK data where they've got a lot of IRE because of Mark Evidence Group. And look, in fact, if you look at the RAFT trial, and if you look also at the, I'd say the seminal paper on this by Paul Cathcart that was published in European Urology, actually after focal therapy, salvage radical is safe. And we just have to be cautious that infield recurrence appear to have a phenotypically more aggressive disease like this guy, which I'll show you. But what I would say is that actually in the series by Paul Cathcart, salvage after cryo, HIFU, and IRE did the best. So it's a small series, but in fact, the functional outcomes and the complication rates were actually fewer after IRE. So that's somewhat reassuring. So this fellow, I was a little bit concerned about a rectal injury, as you would do, for multiple reasons in this guy. And I'm becoming a very big fan of putting Barrigel in. You can see here, obviously, it can be put in under ultrasound guidance. You can even do it a week or two before the surgery, obviously, if you wanted to. And I've done that in a couple of cases. We can see here we get a very good space. And indeed, as far as the situation goes, I think the video is running there, but you can see there that you guys all would be familiar with this. We may have time to see the video. It's only 2 minutes, but here you can see with the robot prostatectomy that I did, you can see the Barrigel here, and here in the plane, and it's pushed everything away, and particularly over the left side. And what I would say is that in my experience with salvage post-radiation and post-nanoknife, what I get reassurance from is you can actually go wider with the margins. So the first goal is to protect the rectum, but I actually think it might allow us to get wider margins on these cases because we're more confident that the rectum is well and truly away. Now, we're very lucky in Australia. The pathologists I use, they give us whole mount specimens on all of our radical prostatectomies. And you can see here, unfortunately, you may see this light yellow halo, which means that there's actually extra prostatic extension. But you'll see here that the margins were clear. And in fact, this gentleman's post-operative PSA is undetectable, and he's had fortunately, a good functional outcome. But what this does show you is that there was a fair bit of Gleason 6 disease, which was being picked up on the PSMA PET, which is unusual, but possible. But that really, unfortunately for me, that although the pathologists tell me there was some treatment artifact in that left area, the IRE just had not done its job. Now, why was that? We've gone back over and we could have perhaps increased the voltage and so on. But I think it's instructive to learn from these sort of cases, and where you can actually compare the whole mount to the PSMA is a big advantage that we have. So I think salvaging, definitely I'm much more interested in utilising all the tools we have, whether it's PSMA and then moving on and using things like Barrigel. So I think we have to accept there will be failures post-focal therapy. We know that. We have to look at strategies to salvage, such as RAP and radiation, which has to be individualised against the disease. And spacing devices, I think, can be helpful. And just also recognising from the Cathcart series that infield recurrences may require multimodality treatment because they're often more aggressive. And this fellow had significant extra prostatic extension, but fortunately his PSA is undetectable. So
yeah, Nate, that's really, really very nice presentation and a great case. So I think this ties back these two cases, your case and also Mike's last case. I think one of the questions was, and in this case, you've demonstrated so nicely that you didn't see the treatment effect you wanted. So in both cases, do you guys think that expanding the treatment margins, treating a greater area, would have made a difference? I mean, I know there are technical differences between IRE and cryo, and maybe you could both, talk about that. But what do you think?
Look, we tend to use very similar parameters for our IRE based on previous work. As I said, we've gone over this one, and I could equally have shown you a 61-year-old where we've done IRE and the MRI shows nothing, the PSMA shows nothing, and the biopsy shows nothing. So I just don't know. I think there is going to be some cases where there's perhaps a technical failure that we can't quite pick yet. Are there cases where we've killed off, say, 80% of the cancer, but then 20% has grown back more fervently? I don't know. fortunately, I've done over 120 IRE cases, and we've only had to salvage 4 of them at this point in time. So I think we're selecting well, but this one I still scratch my head because I think he was a good case for focal. I don't quite understand why there was a technical failure.
Mike, what are your comments?
Yeah, I mean, I think in my particular case, I think, I should have been more ablated a larger area. There was nothing to lose by doing so. It wasn't near any critical structures. So, while the goal is to treat as little prostate as possible to achieve the appropriate oncologic outcome, we can't lose sight of why we're doing so. We're doing so to protect the critical functional structures. And, if as much prostate as you could treat without putting those structures at risk, I think is probably the preferred way to go. And that's kind of the mantra I've been following of recent. So like in that other case, why not have done a hemi? The critical structure was in lesion 1, not near lesion 2, which is where the failure was.
Very interesting. Nate, just coming back to your case, I don't have much experience in IRE, although I find it really interesting. And I just wondered, for a case that's like that, so close to the rectum, do you think there would have been any difference if you had used Barrigel in the first setting? Does it affect, the conduction of electricity? Do you think you could ablate with a larger margin, or do you think it wouldn't really make a difference with IRE?
Yeah, good question. Look, I've used dextrose, which doesn't conduct electricity as well. And I've done that on the day and pushed the rectum out of the way as well, which is another little trick. So, yeah, I think there are some tips and tricks that we can do. And maybe, even using Barrigel would give me the confidence to have ablated more. But we tend to try and avoid the rectum, obviously. And, anyway, I don't know. I think it's just still a work in progress, and we've got to work out how aggressive we can be without causing harm, and that's a challenge for all our focal therapies, isn't it?
Right. Yeah, and I do think that the radical prostatectomy in that last case was a really good decision, because you did find that there was extra capsular extension, and I'm not sure that any if I did a repeat cryo in my hands, it probably wouldn't be complete either. So now, what do you think for HIFU? You said that you would have chosen radical prostatectomy for that patient, but would a repeat HIFU be possible if this patient came to you post-IRE with that recurrence there?
Yeah, so salvage treatment is dependent on the aggressiveness of the recurrent prostate cancer. So the last case was very, very interesting, and I have no experience of the spacer gel insertion, but I will try this.
Okay.
Yeah.
So
inspired by that case to consider using spacer for my treatment naive prostatectomies.
Right.
I mean, that looked great.
So I just wanted to kind of wrap up on this discussion. I think we've run over time for about 12 minutes now. It's 8:42 here in Singapore, and I think it's getting late for you. So Mike, usually I try to keep to the hour, but we really have such nice cases. I just wanted to shout out to the audience. They have some really good comments, and I think we have addressed them. That's why I didn't really raise the questions. Kenneth asked, was there any role of PSMA and MRI to detect lesions missed by conventional biopsy techniques? We answered that. Dan Margolis said that Jim Hu and he had a small in-house trial and found that early appearance of MRI after focal therapy is indistinguishable from abscess, but he thinks that PIFAB has some promise. Dr. Palasic says that we have nice cases and discussion.
I'm sorry, Jack, I didn't hear you say. He found that MRI is indistinguishable from
early abscess. The MRI appearance of early post-focal therapy is indistinguishable from abscess. And Dan's a radiologist, so I think that's how he feels about doing early MRIs. I'm not sure what that means. It just means that, for me, I don't do early MRIs, but I think you guys have shown some nice pictures of how you can get an early feedback on how good your ablation is. So that's some shout outs from the audience. I think just for the audience, this video is going to be available on the FTS website. So go to focaltherapy.org to see this video afterwards, and also any future videos. So I just want to thank everybody again, especially our panel. Thank you so much for coming and showing these very fantastic cases. We are going to plan for our next iteration of focal therapy tumor boards. So that will be in the later half of this year. Look out for our email blast, and we are always looking to improve. So for the audience that's still here, please fill out the evaluation form. So I'm going to ask the faculty to stay behind for a photo, but to the audience, thank you so much. Have a great day and all the best in your focal cases and managing prostate cancer. Thank you.
Thank you.
Thank you very much.